Hi everyone, can you see my slides? Thumbs up or awesome. Thank you. I'll give everyone a few more minutes and then I'll begin just in the presence of time. So I guess we can start since and then anybody who trickles in can just meet us where we're at. Good morning, good afternoon, everyone, and thank you so much for having me today. My name is Keith. I'm one of the vascular neurologists by training. Most of my clinical work is split between hyperacute and acute stroke care. A lot of what I do is inpatient stroke care as well as stroke prevention clinics. So today I want to review modern acute stroke care with a focus on practical updates that affect physicians working here in Scarborough Health Network, regardless of what your subspecialty is. Stroke care has evolved dramatically over the past decade. So we've moved from an era where treatment options were extremely limited to one where we could actually restore the blood flow to the brain in patients who had been left with severe disability. The advances have been driven mostly by improvement in imaging, thrombolysis, and thrombectomy devices, as well as systems of care. However, one important point I really want to emphasize is that many of the decisions that determine whether a patient ultimately receives treatment occurs before a stroke neurologist even arrives. Excuse me, I'm a little under the weather. They usually happen in the emergency department, on the wards during transfer, and even during other procedures. And so it's during this early physiological event where management is key. So my goal today is just to review what has changed in acute stroke care and also discuss several important updates in stroke prevention that affect many of the patients we care for. So today I want to focus on four main objectives. First, we'll review what has changed in acute stroke management in recent years. Second, we'll talk about how to act faster because time still remains one of the most important determinants of the outcome of stroke care. Third, discuss who should be treated today, who actually wasn't treated previously. And finally, review some of the more modern stroke prevention strategies, including new evidence regarding anticoagulation timing, carotid disease management, malignancy-associated stroke, and the management of cerebral amyloid angiopathy. So acute stroke care has changed a lot, particularly over the last 5 to 7 years. So historically, we're trained to think almost entirely in terms of time. So 4.5 hours, 6 hours, 24 hours. Time still matters tremendously, but it's no longer the only thing that matters. We now understand that stroke prevention is highly variable. Some patients lose brain very quickly, and others maintain viable tissue far longer than expected. And this is what we refer to as fast versus slow progressors of infarct growth in these large vessel occlusion strokes. And again, not everyone progresses to infarct at the same rate. Instead, infarct growth exists along a spectrum. It's driven primarily by collateral blood flow and cerebral ischemic tolerance, and so not time from the symptom onset alone. And it's because of this that stroke care has become much more physiological based. We're asking whether there is salvageable brain tissue, not just when the patient first started having symptoms. And I think this shift really affects everyone. It's not just myself as a vascular neurologist, but internist ICU teams, procedural teams, who often are the first ones seeing the patients. Even before imaging, there are several aspects of acute stroke care that have shifted towards a single guiding principle, and that's really optimizing cerebral perfusion as early as possible. I think head of bed positioning is a good example of this. Patients were routinely positioned at a 30-degree angle for aspiration risk. We actually now recognize that in carefully selected patients with a protected airway and no active vomiting, placing the patient flat can actually meaningfully improve the cerebral blood flow. And that's what will support the ischemic penumbra even before imaging is obtained. The other thing that is moved in a very similar direction is blood pressure management. Rather than aggressively lowering blood pressure prior to imaging, we now aim to preserve perfusion unless blood pressure is severely elevated. That's greater than 220. Any sort of reductions can compromise collateral flow and accelerate the infarct growth. And that's the same as with glucose management as well, where we're more pragmatic. Hypoglycemia is clearly harmful, and we try to avoid chasing that perfect glucose targets acutely. We're only really treating significant hyperglycemia. And that's because treating glucose and having a hypoglycemic attack can actually be worse for the patient. So this reflects a broader shift towards protecting vulnerable brain tissue from very first medical contact. Now, imaging has become the backbone of modern stroke. It's probably one of the biggest practical shifts in how we make decisions. Most protocols that you'll see now include a non-CT or non-contrasted CT. You also have a CT angiogram and a CT perfusion. The non-con CT is what helps me rule out if there's a hemorrhage or not. The CT angiogram identifies if there's a large vessel occlusion. The CT perfusion identifies if there is an infarct core and if there's a penumbra. So the idea that time windows are fixed and absolute is no longer accurate. Instead, when we use these advanced imaging protocols, particularly CT perfusion, it really allows us to direct and
They need to see her now.
oh, sorry, I think someone is. I'm just gonna mute you. So what I was saying is that particularly CT perfusion allows us to directly assess what we actually care about. How much brain is already infarct and how much brain is still salvageable. That's the key concept. That's the key thing that's changed. We still use aspects. Aspects still matters, but I think the key is that we're no longer using it in isolation. The aspect score is something very different when it's paired with a favorable perfusion as opposed to when it's not. And I'll use this, I'll demonstrate this in an example because I think it's helpful. Because it helps us in both directions. It prevents us from treating patients who are unlikely to benefit, but it also prevents us from denying treatment to patients who still have valuable tissue simply just because they're outside a traditional time window. So, for example, you take two patients who both present with the same aspects of 6 on a non-CT, a non-contrasted CT. The first patient has a CT perfusion that shows a large core with minimal penumbra and has poor collateral flow. In that context, an aspects of 6 would likely reflect an advanced infarction, and a potential benefit from reperfusion would actually be limited in that case. And there's a higher risk for hemorrhagic risk, transformation. Now, in a second patient, the aspects is also 6. CT perfusion demonstrates a small ischemic core with a large volume of salvageable penumbral tissue. And this person has good collaterals. In this setting, the same aspect score tells you a very different story. This patient may still derive substantial benefit from reperfusion, even if they're outside the traditional window. So what I mean by this is the aspect still matters, but it only becomes clinically meaningful when we interpret it alongside a perfusion imaging or based on the physiology. So from a systems perspective, this means that the fastest patient isn't the one who skips imaging, it's the one who gets the right imaging earlier, without delays, without debates. It's once a team is comfortable with this workflow, decisions actually become clear and more consistent. And it allows us as a hospital network that transfers to outside hospitals to be more clear and concise with our decision-making plans. One of the other things that has changed is thrombolysis. It's another area where practice has evolved very practically. It was a Canada-driven clinical trial where it's workflow-driven. Tenecteplase has now replaced alteplase in many centers. It's largely because it simplifies care. It's given as a single bolus. It reduces infusion-related delays, and it integrates more smoothly in emergency departments and with transfer workflows. The other major change is how we approach wake-up and unwitnessed strokes. These patients are no longer automatically excluded from thrombolysis. If advanced imaging shows a favorable pattern, meaning there's salvageable tissue, we still activate a code stroke and involve stroke expertise early. In practice, this has expanded access to treatment without increasing harm. It shifted the mindset from are they outside the window to now is there any brain that we can still help salvage? The other thing that has been one of the more visible changes in stroke care is thrombectomy and the decision behind it. It has become more nuanced rather than more aggressive, I think. One of the major shifts is how we think about large core infarcts. It used to be that patients who had aspects less than 5 were automatically excluded from being a thrombectomy candidate, but actually patients with aspects in the 3 to 5 range who were previously considered poor candidates through the Select 2 and Angel aspect trials have shown that they can still benefit, particularly if they present early and have severe and clearly disabling deficits. Again, most of what I'm trying to express here is that we shouldn't exclude patients automatically based on time or based on the initial assessment, but really looking at what we can do in these cases to eliminate and improve any potential benefits. Another change in our approach is to distal vessel occlusions or MIVOs. There are still very much case-by-case decisions. There are cases that we may not take, even if it's the same vessel that's occluded. And most of this relies specifically on key aspects, such as if they have a high NIH stroke scale or disabling symptoms. And these still deserve discussions rather than dismissals. We're not just saying you have an M2 occlusion, you're not a candidate. It's actually based on clinical description as well. For basilar artery occlusions, the data has really solidified. ET improves outcomes, and waiting for MRI should not delay treatment in appropriate patients. I think the practical takeaway is early recognition, early imaging, and rapid transfer, because those are the steps that I think ultimately determine outcome. Now, for post-reperfusion care, one of the most important principles is avoiding blood pressure variability. It's not just hitting the target number, it's large swings in blood pressure, especially hypotension, are actually associated with larger infarct expansion and hemorrhagic transformation. In practice, we generally aim for systolics within the 140s to 160s and are particularly cautious when MAPs go below 70s or systolic pressures are under 120. Another area where practice has evolved is the timing of anticoagulation, particularly in patients with atrial fibrillation. And we'll get more into this in a few slides ahead. But the key change is that the decisions are now individualized and imaging guiding rather than uniformly delayed. Another very common question we encounter is in stroke prevention is when we should use dual antiplatelet therapy and for how long. For most ischemic strokes, we typically use single antiplatelet therapies such as aspirin and clopidogrel. However, there are certain situations where dual antiplatelet therapy provides additional benefits, particularly in early periods where risk of recurrent stroke is highest. The two major trials that guide our practice here are the CHANCE trial and the POINT trial. These trials look at patients with minor strokes or high-risk TIAs and demonstrate that starting aspirin and clopidogrel together early after events significantly reduces the recurrent stroke risk. However, an important finding from these studies is that the benefit is primarily in the early period, and that's within the first few weeks after the event. After that, the risk of bleeding begins to increase. So for most patients with minor strokes or high risk TIAs, the standard approach today is aspirin plus clopidogrel for 21 days, followed by a single antiplatelet agent. You may know that there is an important exception to this rule, and that involves the patients that have intracranial atherosclerotic disease. This is where the SAMPRAS trial becomes important. So SAMPRAS compared intracranial stenting versus aggressive medical therapy for patients with symptomatic intracranial stenosis. The trial showed that aggressive medical therapy was actually superior to stenting, largely due to complications related to the procedures. But aggressive medical therapy in that trial included dual antiplatelet therapy for 90 days, along with intensive risk factor management. The reason dual antiplatelet therapy is continued for 3 months in these cases is that the lesion has a very high early recurrence risk, particularly in the first few months after the initial event. The concept is that the plaque is unstable, the vessel lumen is severely narrowed, and a small platelet-rich thrombi can repeatedly form at the stenotic site. So dual antiplatelet therapy helps reduce the early thrombotic risk while the plaque stabilizes under the aggressive medical therapy, which includes using statins and blood pressure control. In practical terms, our approach is for minor strokes or high-risk TIAs. That's where we use the ABCD2 score without intracranial stenosis, dual antiplatelet therapy for 21 days. And for patients that have symptomatic intracranial atherosclerosis, we extend dual antiplatelet therapy to 90 days. After the 3 months, we typically transition back to single antiplatelet therapy. And the key takeaway is duration of dual antiplatelet therapy is dependent on the underlying stroke mechanism. Another important area where our practice has evolved significantly is when we restart anticoagulation after an ischemic stroke, particularly in patients with atrial fibrillation. AFib, as you may know, is one of the most common causes of embolic stroke, and the risk of recurrent emboli in the early periods after stroke can actually be quite high. Historically, we have always been cautious about restarting anticoagulation too early because we're concerned for the risk of hemorrhage or transformation of the infarcted area. And so for me, during medical school and residency and fellowship, many followed the rule of 13612, which was largely based on expert consensus. It was rather than randomized trials. And so the rule kind of suggested that after 1 day, you would start anticoagulation for a TIA, after 3 days for small infarcts, after 6 days for moderate infarcts, and after 12 days for large infarcts. Now, the concern with this was that early anticoagulation could increase the risk of intracranial bleeding within the infarcted area, and so that's why there was the delay. However, recently, and until recently, we didn't actually have any actual strong randomized evidence to guide this decision, and this is where the ELAN trial became important, and I think that it's really helped delineate our treatment plans and management in these cases. It was a randomized trial that compared early versus delayed initiation of direct oral anticoagulants in patients with atrial fibrillation who had suffered an ischemic stroke. And the patients were randomized based on infarct size. So you had in one group, which was the early treatment group, anticoagulation was started at within 48 hours of a minor stroke, within 48 hours of a moderate stroke, and then within 6 to 7 days of a major stroke. And then in the delayed treatment group, it was started later, typically around day 3 to 4 for minor strokes, day to 6 to 7 for moderate, and day 12 to 14 for major. Now, what the study showed was that starting anticoagulation earlier didn't significantly increase the risk of symptomatic intracranial hemorrhage. At the same time, earlier anticoagulation may actually reduce the risk of early recurrent embolic strokes. So what this means for clinical practice is that we're now less conservative than we were before about restarting anticoagulation. From a practical term, our current approach often looks something like this. So for TIAs, anticoagulation is usually started immediately. For small infarcts, we usually do it within 48 hours to 72 hours. Moderate strokes, typically day 3 to 4, and large strokes, 6 to 7. And that's really dependent on imaging and the presence of hemorrhagic transformation from the original scans. So one important point to actually emphasize is that the decision should always incorporate repeat imaging. And this is particularly important in patients who have larger infarcts. If there's still significant hemorrhagic transformation on imaging, then we still will delay anticoagulation further. And that's when we get into the day 14 and even day 30s, depending on the underlying reason that we think that the bleed occurred. But overall, the key takeaway from Milan is that early anticoagulation is generally safe and may reduce recurrent embolic events. And this is particularly in patients with smaller infarcts. And because recurrent embolic strokes can occur very early after initiation, early treatment strategy may actually improve their outcomes. So another area where stroke prevention decision has evolved is actually in carotid artery disease, specifically when we should intervene with carotid endarterectomy or stenting. Now, I think it's helpful to divide the discussion into symptomatic carotid stenosis and asymptomatic carotid stenosis because the evidence and management strategies are a little different. Let's start with symptomatic carotid stenosis because this is where the evidence for intervention is the strongest. Symptomatic carotid stenosis refers to patients who have had strokes or TIs in the distribution of the carotid artery. Typically, these patients present with symptoms such as unilateral weakness, aphasia, amaurosis fugax, or transient monocular blindness. And the landmark trials that guided our practice here are the NACID and ECST, which demonstrated that carotid endarterectomy significantly reduced stroke risk in patients with severe symptomatic stenosis. So in general, for patients with a 70 to 90% stenosis, carotid endarterectomy clearly provides substantial benefit over medical therapy. Now, in patients with moderate stenosis between 50 and 70% or 69%, the benefit is still there, but it's more modest compared to the higher percentage. And surgery should still be considered, especially if the patient's factors such as age, comorbidity, and surgical risk are all within targeted factors. One of the most important aspects of symptomatic carotid disease is timing. The benefit of carotid endarterectomy is greatest when the procedure is performed as early after the index event. I know we say ideally within 2 weeks of a stroke or TIA, but the earlier the better, um, as it has shown to have better benefit and better outcomes for the patient. And this is because the risk of recurrent stroke is highest during that early period. And so when a patient presents with a stroke and is found to have severe ipsilateral carotid stenosis, after you determine that that's the cause, this should trigger an urgent evaluation for vascular or neurosurgery or whoever you are referring the patient for a carotid endarterectomy or stent. Um, The other thing that I wanted to briefly mention was when do we prefer CEA, when do we prefer stenting? And so generally when um, someone is having symptomatic stenosis between 70 to 90%, their age is greater than 70, and they have standard surgical risk, a CEA is preferred. Stenting is considered when patient is a high surgical risk. If they've had prior neck surgery or radiation, there's a high carotid bifurcation, there's some form of severe cardiopulmonary disease, or they've even had restenosis after a prior CEA. Now, we're going to contrast this with asymptomatic carotid stenosis, which was much more controversial. Historically, many patients with asymptomatic carotid stenosis who underwent surgery based on older trials had a moderate or very modest benefit. And this has changed over the past 2 decades, especially with medical therapy improving dramatically. Um, so the natural history of asymptomatic carotid stenosis has changed. So the annual stroke risk in medical treated patients is now approximately 0.5% to 1% per year, which is much lower than what it was earlier in surgical trials when it was performed. But as of last year, the CREST-2 trial, which was designed to address this issue directly, comparing carotid revas with aggressive medical therapy, had its results published, and this actually suggests that intervention may benefit selected patients, particularly those with severe stenosis of 70% or greater, who have a low surgical risk and a reasonable life expectancy. And so this is one of the bigger changes, and this is something that you'll start to see practice change dramatically, is that patients that have asymptomatic stenosis will be more likely to have CEAs and intervention. This, however, is important to understand in that aggressive medical therapy remains essential regardless of whether intervention is performed or not. So in practical terms, the patients we consider for intervention are very high grade stenosis, good surgical risk, on treatment, and life expectancy greater than 5 years. So this is one that I think I'm asked a lot more about, and it's another complex situation we encounter in stroke prevention clinics, and you may encounter while in the hospital, and these involve patients with cerebral amyloid angiopathy, particularly when they also have an indication for anti-thrombolytic therapy, such as atrial fibrillation. So cerebral amyloid angiopathy, or CA, is a common cause of lobar intracerebral hemorrhage in older patients. It results from deposition of amyloid within the walls of the small cortical and leptomeningeal vessels. And then this deposition is what weakens the vessel walls and makes them prone to rupture. One of the challenges with CAA is that the risk of recurrent hemorrhages can be quite high, particularly when certain MRI findings are present. And so an MRI is extremely useful in risk stratification for these patients because there's several imaging markers that significantly increase hemorrhagic risk. The most important one includes prior lobar intracerebral hemorrhage, multiple cortical microbleeds, especially if they're in a lobar distribution, and if they're greater than 100 microbleeds, cortical superficial siderosis, which essentially represents a prior bleeding area along the cortical surface. And so you can actually see it in the image on the far right. You can see the white on the corner over there, and so you can see that that's some siderosis. The middle is the multiple cortical microbleeds, and the one on the left is lobar hemorrhage. So among these markers, a cortical superficial siderosis is particularly concerning. It re and that in combination with extensive white matter disease associated with fragile small vessels, because it suggests repeated bleeding from these fragile cortical vessels is particularly high. So when we evaluate patients with possible CA, one of the key questions that we usually get asked is whether antithrombolytic therapy is still safe. Now, let's start with anticoagulation because I think that's an easier question and it's also the one that's most concerning. If a patient has probable CA and that's with a prior lobar intracerebral hemorrhage, most stroke neurologists would strongly consider avoiding long-term anticoagulation, and this is because the risk of recurrent ICH can exceed the benefit of preventing any ischemic strokes. In these cases, we often explore alternative therapies such as a left atrial appendage occlusion device, aggressive blood pressure control, and even individual stroke prevention strategies. If patients come in without prior hemorrhage and the MRI shows numerous lobar microbleeds or extensive superficial siderosis, the hemorrhage risk with anticoagulation becomes concerning. In these situations, we also avoid anticoagulation, and that's dependent on the patient's embolic risk. Now, the decision around antiplatelet therapy is a slightly different. Aspirin carries less hemorrhage risk than anticoagulation, but it's not completely benign. And so, in patients with probable CA or prior lobar hemorrhage, even aspirin may increase the risk of recurrent bleeding. And so, in these cases, we sometimes choose to avoid antiplatelet therapies as well, particularly if the indication for being on aspirin is weak. For example, if aspirin was used for primary prevention, we would almost always stop it. However, if a patient had a strong indication, such as recent coronary stenting, the decision becomes more complex, and that requires a multidisciplinary conversation. But in general, the factors that kind of push us towards stopping antithrombotic therapy include prior lobar intracerebral hemorrhage with extensive cortical superficial siderosis or with numerous lobar microbleeds on MRIs or evidence of recurrent hemorrhage. And the most important modifiable risk factors for any of these cases is blood pressure control. And in these cases, strict blood pressure management significantly reduces the recurrent hemorrhage risk. So when managing patients with suspected or confirmed CA, we rely heavily on MRI markers to estimate their hemorrhagic risk. And in patients who are high-risk imaging features, we tend to avoid anticoagulation unless the benefits are outweighing the risk. And these decisions generally are individualized and they do involve careful discussion with the patient and their family around balances. So another one that's important to me and something that I do at my UHN clinic is malignancy-associated strokes. Um, as cancer therapies improve, patients live longer, and we're starting to see the mechanism of stroke more frequently. Um, Tumor cells release procoagulant substances and tissue factors and inflammatory cytokines and mucin-related proteins that activate the coagulation cascade, and this leads to thrombin generation and um, systemic hypercoagulability. And so one of the clues that a stroke may be cancer-related is imaging pattern. Patients often present with multiple infarcts. They almost look like they're embolic, but they're in different vascular territories. And this is in a context of someone not having any other underlying cardiac cause. Um, the other thing that we look at is the type of cancer as well. And another talk would be talking about the number of different chemo-regimented medications that can also have a higher risk of thrombotic risk. And if anybody has questions about that, I'm happy to talk about that after. But in general, cancers with a stronger association with stroke include pancreatic, which I think has the highest thrombotic risk, lung cancer, particularly adenocarcinoma, the GI cancers, ovarian cancer, and certain hematological malignancies, those that already have abnormal coagulation pathways. Um, and in management in these cases is different, typical to a normal ischemic stroke. Antiplatelet therapy usually isn't sufficient because the underlying problem isn't platelet activation, but rather coagulation activation. And so for this reason, standard treatment is therapeutic anticoagulation. I know there's been a trend to move more towards direct oral anticoagulants. I think in our practice with thrombosis, we still like to use low molecular weight heparin, such as enoxaparin for these cases. They just have historically um, appear more effective than vitamin K and antagonists for preventing recurrence. Another challenge in these is the recurrent strokes that are common in these patients, and sometimes even while on anticoagulation. What our practice is that is to increase enoxaparin to approximately 120% of the standard weight-based dose if there is a true breakthrough stroke related to malignancy. Again, often this is done in close multidisciplinary management with oncology as well. And so um, these tend to be cases that, as the cancer worsens, the clinical complications associated with anticoagulation become worse. PFO closure has become standard for selected patients with cryptogenic stroke. So these are generally patients younger than 65 who you've ruled out other reasons for the stroke. That includes more common features such as ICAD, vasculitis, as well as malignancy screens. These are typically younger patients who have high-risk PFO anatomy and usually have large shunts or atrial septal aneurysms. Um, And so these are careful patient selection, and I think that in these cases, patients tend to do well, um, and uh, uh, and so I think this has become more standard of practice now. I put this into the slides because this is something that has become more common practice, especially as it's become more particularly relevant in patients with cerebral amyloid angiopathy or prior intracranial hemorrhages. And this is where you're hesitant to restart anticoagulation, but still want to reduce the embolic stroke risk. So we frequently encounter these patients who are very high bleeding risk, and they've had prior ICHs, CA, recurrent GI bleeding, severe fall risk, or other contraindications to being on long-term anticoagulation. And so for these patients, continuing anticoagulation might actually pose risk than benefit. And this is where left atrial appendage occlusion devices come into play. So the most widely used is the Watchman device, although several others now exist, and the procedure is performed by interventional cardiology. And so with the Protect AF and Prevail trials, the left atrial appendage occlusion is non-inferior to warfarin for stroke prevention in selected patients. And so these devices have increasingly been used specifically in patients who can't be on anticoagulation safely. The one caveat to this is that patients do require anticoagulation in the short term, so they still need to be safe from that perspective. And then there's the other cardiac evaluation that is required before a patient can effectively undergo one of these treatments. And so this is something that I wanted to bring light to as these procedures are becoming more common and they actually represent an important alternative strategy for stroke prevention in patients where anticoagulation is unsafe. So, key takeaways are stroke is evolving rapidly. Imaging now guides treatment more than rigid time windows. Thrombectomy eligibility has expanded. Physiological management in the early hours is still critical, and stroke prevention strategies are becoming increasingly individualized. Thank you. If anybody has any questions, I'm happy to take them, or can give you guys 15 minutes back.
Thanks, Keith. This is Derek.
Thanks, Derek.
We can maybe talk about this somewhere else later, but the in deciding the timing for anticoagulation for patients with strokes, sometimes I find one of the difficult things can be with the larger ones, like distinguishing between like laminar necrosis and luxury perfusion sort of things and true like petechial hemorrhage. I don't know how often you sort of, if you have any approaches. I find sometimes we get like scan after scan after scan, and like you see, okay, they're not really changing. Like this hyper density is just in the same spot. And then, you know, eventually you sort of say, okay, this isn't really active hemorrhage.
Yeah, I think that that's a great principle, and I think one of the things that we've had the luxury to use is dual energy CTs to see if it's truly hemorrhage or not. I mean, with laminar necrosis, I think that after 48 hours of stability, if you don't see any other features of it, what what I've taken the approach of doing is a slow titration. So this is where you guys might have seen that uh, they do a reduced dose of enoxaparin to see if that triggers any hemorrhagic transformation, and that's more of something that is, I think, more nuanced and discussed with the family, because that's where I think I would do it in those cases where there is a higher risk for bleeding, um, or sorry, a higher risk for thrombotic risk.
Yep.
Versus if it's someone who the risk is higher, I usually would hold off and repeat an MRI in a month or two, if I have the luxury of that, and then start anticoagulation after that to see if anything has changed or if there's been any progression. I think sometimes when we repeat the CTs too often, uh, we don't necessarily get the information we want, and we're sort of pigeonholed into continuing a similar practice because we haven't seen any new information.
Yeah.
Um,
Yeah. Yeah. Thanks.
All right, I think that that is good. If anybody has any questions, feel free to email me. I'm always happy to answer any questions. I put my email in the chat as well in case you have any questions about any specific patients. Happy to always give my advice if I can. Have a great day, everyone.
Thanks, Keith.